Hello everyone. So I was talking about androgenic alopecia a few hours ago. Right now I will continue my topic. So grade 2 system of Norwood classification. So in grade 2 system of Norwood classification, hairline is one finger breadth behind the upper brow crease area. Frontotemporal recess will appear in male, while in female hairline is head shoe shaped. Frontotemporal recess will not go beyond 2 cm ahead of in each ear canal in a vertical plane. In grade 3 system of Norwood classification, it will go beyond the ear canal in a vertical plane. Now, grade 3 vertex pattern. This is a picture of a grade 3 vertex pattern. Now you can see in grade 3 vertex pattern, the vertex area is involved. You can see here small patch of alopecia in vertex region. So it is more common in crown area. Baldness may reach up to 3 inch with minimal hairline problem. Frontotemporal recess will not go or will not cross the vertical plane of external auditory canal. In grade 4 system, there is uh, temporal recession go beyond middle coronal plane, and baldness in a crown area is greater than 3 inch in diameter. Now this is a grade 4 system of Norwood classification. This bald area is greater than 3 inch right now. In grade 3 vertex pattern it was less than 3, but right now it is greater than 4 inch in diameter with persistence of swath of hair in crown area. Now this is a swath of hair. This is clear cut visible. Now if this swath of hair is more than 3 inch, it fall into grade 4 system of Norwood classification. If it is less than 3, then it will fall into grade 5 system of classification. Now in grade 5, there is a decrease of swath of hair between the frontal and back, and fringe of the hair is less than 3 inch and breaks down. Now this is the grade 5 system of Norwood classification. Now you can see this swath of hair was clearly visible here in this 4. Now it is completely reduced, and this fringe of the hair is here, it is broken. You can see in 6 it is very clear, but in 5th it is very fine and near to break. So within grade 5, decrease of swath of hair between the frontal and back side area, and fringe of hair is less than 3 inch and it is about to break, but situated in between the crown area and occipital protuberance. Now this is the fringe of the hair. It is situated in between the crown. This is the crown area, and this is external occipital protuberance area. So this is located in between them. Now grade 6 of Norwood classification. No swath of hair. There is silk of plain area, or you may say there is a silk of baldness with horseshoe shaped pattern of hair loss in crown area. Now this is the actually the grade 6 system of Norwood classification. You can see there is complete baldness. The frontal vertex area is completely lost. There is no swath of hair, as you have seen previously in this picture. There is a swath of hair. In grade 3 there is a swath of hair, but in grade 6 the swath of hair is completely lost, and it is horseshoe shaped in the structure. So you can say that within grade 6 system of the classification there is completely a loss of hair. Now the fringe of crown area dip down into the horizontal place of a bony contour. Now this area, actually this is area the fringe of the hair. It will down horizontally into the uh, back side of the scalp. Now if the fringe of the hair go beyond 3 inch and enter in 3 inch, then it will enter into the grade 7 system of classification. Now this is actually fringe of the hair. It will go beyond 3 inch and in downward direction. So this is a grade 7 system of the classification. Now if the fringe is less than 3 inch in diameter and does not go into the horizontal area on the back side, then it is said to be in grade 6 area of Norwood classification. If it go beyond the uh, the 3 inch, then it is entering into grade 7 system of Norwood classification. Now this is a picture showing the pattern of hair loss in female. This one is a normal. You can see this is normal area. This is central area without any widening. In second picture there is a widening of the scalp seen in female. In third picture there is extensive widening involving the both parietal region of the scalp, and in fourth picture there is a further widening of the central parting line, and in fifth picture there is almost completely widening of the central parting line involving both parietal region on the scalp. Investigation. Now for suppose if hair loss is sudden and people say that, our patients say that my hairs are completely lost suddenly, then go for medical history and examination immediately. Medical history and examination include endocrine examination to rule out virilizing tumor. Now if the hair loss is noted gradually, then menstrual disturbance, hirsutism and acne must be considered. Now diagnostic test. There are 4 diagnostic tests which are very helpful. Number one is the hair pull test, and this hair pull test is already discussed in my previous lecture. You can follow my YouTube channel to see the methodology of hair pull test. Number second is the handheld illumination test. This test involves illumination of light to visualize the scalp and follicular area. And number third is the global photography. This is very important. The global photography of scalp and follicle may give evidence of hair loss time by time. And number fourth is the scalp dermoscopy. It involves dermoscope which magnify the hair and follicles up to power of 1000, so that the hair and scalp can easily be visualized. Investigation in female pattern hair loss. Now the following investigation must be considered in female. Number first is the full blood count, serum ferritin, thyroid function test, fasting lipid, fasting glucose. Now if there are signs of virilization or hirsutism in female, then go for serum testosterone, dihydroependyrosterone sulfate. This test is very much important. Morning sample on the day 1 to 5 of a cycle need to be considered. Make sure that the patient is not on the oral contraceptive pills. If a patient is on oral contraceptive pills, the result will be changed. Another test is the 17 hydroxyprogesterone, androstenedione, ovarian ultrasound, adrenal imaging. These are the tests which are usually be considered when you are dealing with the patient of female pattern hair loss. Scalp biopsy. Biopsy routinely not advised, but when advised, it is advised for distinguishing between the hair loss due to trichotillomania and female pattern hair loss. Most accurate for diagnosis is triple biopsy from the vertex area. Another biopsy is punch biopsy. In this biopsy, we usually take horizontal section of 4 millimeter and then we send it for the histopathology. If the ratio is greater than 8 is to 1, it favors trichotillomania iplium, and if it is less than 4 is to 1, and then it favors female pattern hair loss. Management. Now, in androgenic alopecia, the counseling is very much important. The counseling is main tool. Sustained therapy is mandatory for sustained effect. The camouflage are used. These are actually the small fibers held electrostatically in between the hairs and dyeing scalp the same color to create illumination of thicker hair. And third type of the management are the use of wigs. We all are aware of the wigs. These are actually the synthetic acrylic fibers, very easy to style and very last longer. Medical management, anti-androgenic 5 alpha reductase inhibitors and minoxidil are the management of choice. Dealer suggested good response of minoxidil if it is used early in androgenic alopecia in a less than 10 cm in a bald area and 20 hair per centimeter per pre-management density. Benefit. Benefit is good in first 6 months of the therapy. Side effects are local irritation, hypertrichosis, mild contact dermatitis. For good use, minoxidil once or twice daily for indefinite period must be used. Finasteride. It antagonizes 5-alpha reductase enzyme type 2 isomers to inhibit conversion of testosterone to dihydrotestosterone. 1 mg daily is effective in early stage